Good morning, ma'am.
Good morning.
Good morning.
Can you hear me, right? Can you hear me?
Yes, ma'am. Audible, ma'am.
Okay.
Good morning, sir.
Morning. Good morning, Dr. Shubha.
Good morning, sir. Sir, I'm not a doctor yet, sir.
Komal?
Good morning, sir. Good morning,
Yes.
ma'am.
Shall we start with the program, sir, with
Yes.
your permission? A warm good morning to one and all. There are three principal means of acquiring knowledge: observation of nature, reflection, and experimentation. Observation collects facts, reflection combines them, experimentation verifies the result of that combination. It's my lovely obligation to offer each of you the pleasant greeting and to bid you all a genuine welcome for Day 3 ICARP 2021. So let's open the third day of this global gathering for this international conference to discuss and share the information on advanced research in pharmaceutical healthcare sectors organized by Faculty of Pharmacy, Dr. MGR Educational and Research Institute, Chennai, in association with Pharmacy Council of India, Indian Pharmaceutical Association, Tamil Nadu State Branch. The thrilling recent 2 days of this conference was very much fruitful and informative, where I need to thank our speakers, guests, and each and everyone who helped us to make it a grand success. To summarize Day 2 conference, it has been inspired by two eminent speakers, Dr. Muthukumar Krishnamurthy, Research Fellow at Houston, DBEC Heart and Vascular Center, Texas, USA, discussed a topic on nanomaterials and its potential importance in drug delivery and regenerative medicine, followed by Dr. Balarama Kumar Komana, Assistant Professor, School of Pharmacy, College of Health and Medical Sciences, Haramaya University, Ethiopia, has discussed a detailed study on forced degradation of pharmaceutical dosage forms by RPHPLC method. Furthermore, today it's another day to add on more information from this total instructive bundle of conference, from which our knowledge and skills are emphasized through all our eminent speakers who gave and who are also awaiting to illuminate various topics on research advancements and its development technique. In this juncture, I would like to register my heartfelt gratitude to our founder chancellor, Dr. A.C. Shanmugam sir, our beloved president, Engineer Thiru A.C.S. Arun Kumar sir, and our Honorable Secretary to A. Ravi Kumar sir, our Vice Chancellor Madam Dr. S. Geeta Lakshmi, for their constant support and encouragement in all our development. I also extend my exultant gratitude to our chief guest of this conference, Professor Dr. Shailendra Saraf, Vice President, Pharmacy Council of India, and Sri J. Jayasilan, Chairman, IPA Industry Division President, Tamil Nadu Pharmacy Council Chairman, IDMA. I also welcome all the speakers of this conference from various places outside India who has been presenting and sharing huge knowledge about pharmaceutical information, which is enlightening us and on various curiosities and thirst to learn more. Last but not the least, I also welcome all my colleagues, research scholars, students, and all the participants from all over the world who has registered and participating to gain and trade more insight and to learn new data of various informative 10 topics on advancement research of our pharmaceutical healthcare sector. Today, we have two eminent speakers to decorate the ICARP 2021, Ms. Subhashini Raman, Product Specialist, Faculty of Chemical and Process Engineering Technology, University, Malaysia, followed by Mr. Venkataraman, Research Fellow at Italy. So I request each and everyone to utilize this impending hours and enlighten yourself with an incredible information. I thank our management and Principal Sir for granting this opportunity to welcome everybody for this huge conference. Without any delay, I would like to invite Dr. Sendilraj Sir for introducing our today's speaker, Ms. Subhashini Raman, Product Specialist for this today's ICAR 2021 Day 3 session. Dr. Sendilraj Sir.
Good morning, ma'am.
Morning, sir.
Subhashini completed her degree in pharmaceutical engineering and in University of Malaysia, Bank, and a master's in pharmaceutical nanomedicines from the same university. And in work experience, she worked as a teacher in MGS ACS Methodist School and a brand advisor in Unilever Holding Company in 2016, and worked as pharmacy executive in Comedy Holding Indra Maternity Home, and also got Duro Pharma Biotech Parrot internship, and worked as research officers in UMP Research Innovation Center in 2019 to 20, and now working as technical specialist in Analysa Resources. And he also got some medals in Japanese choral speaking national level, first place in 2011, and International Festival of Innovation Technology Awards, and also participated Youth Academic Leadership Convention in 2017. She done a lot of research in nanoparticles and also published a lot of papers in Scopus, and currently doing the research in nanoparticles regarding the neurodegenerative disorders. Thank you, ma'am. I am welcoming you for the today presentation. Thank you, ma'am.
Thank you, sir. So I can start, sir?
Yes, ma'am, you can start sharing your screen.
Okay, thanks. Okay, can you see my screen right now?
No, no, ma'am. No, it's
No,
not
ma'am,
visible. ma'am.
not visible, ma'am.
Okay. Okay, now?
Yes.
Yes, ma'am.
Okay. How shall I put this thing off? Okay. Okay, so very good morning to everybody present here in this conference. I'm glad that you all have invited me and given me this opportunity. So I would like to share a bit from my research and what I've experienced in. So I'm Subhashini Raman, you can call me Subha, and I've actually done my master's in pharmaceutical and currently working on brain research. So my topic today is on neurodegenerative diseases and our human brain. So talking about human brain, right, we are the most complex organism and we are the most smartest on the earth because imagine when it comes to computers and all the softwares, it has been designed by a human brain and everything is done utilizing our human brain itself. There's nothing greater than our human brain. So anything that is even, let's say, when it comes to disease itself, a disease can also be cured with our own psychological and also strength of our thinking skills. So that's how powerful our brain is. As long as you think you can do it, you will definitely do it. As long as you think that something that you actually caught up with disease or anything, the willpower will actually able to create the energy for you to, get out of that particular situation. That's a simple brief about we, ourselves, and our human brain. Okay, so moving on to neurodegenerative diseases. So first of all, I would like to talk about neurodegenerative. What is neurodegenerative disease? So basically on the title itself, neurodegenerative, it clearly shows that the neurons are getting degenerated. So it's basically the neurons are dying, or we can call it as a progressive loss of structure or function of neurons, including that of neurons. So it can happen to anybody at any age. Actually, it doesn't really cater or capped up to the age of old age or 60 to 65 years. But I do understand that when it comes to neurodegenerative diseases, we all understand the age that we are concerned of is at 60 years and above. But to be honest, it can actually happen to anybody at any age. So talking about neurodegenerative diseases, there are so many diseases under this category, and I'm going to talk about some, which is the most famous one, Alzheimer's disease and Parkinson's disease in my talk today. And the balance, which we commonly might look into, is prion disease, motor neuron diseases, Huntington's disease, spinocerebellar ataxia, spinal muscular atrophy. So other than these 6 or 7 categories of diseases, there are so many other neurodegenerative diseases that which is available, which is actually recognized in our medical field. So, and these diseases actually varies depending on which part of the brain is impacted, which part of the brain where the neurons are dying. So that's how we classify this kind of diseases. Let's say for Alzheimer's disease, the neurons are actually getting affected in the hippocampus. So that's why it's actually affecting the loss of memory and all. So moving on further, I would like to talk about the World Health Organization statistics and also their research on the current population affected with these neurodegenerative diseases. So basically AD, PD, okay, AD is Alzheimer's and PD is Parkinson's disease. So AD, PD, stroke, headache, brain injuries, epilepsy, neuroinfections, and multiple sclerosis currently affect over 1.5 billion people worldwide. And out of this, we can easily see 4.4 million people. Is anyone talking to me? Hello? Hello?
No, ma'am, you can continue.
Oh, okay. So 4.4 million people are being affected with Alzheimer's disease worldwide. And 7 to 10 million people are affected with PD worldwide as well. So this is not a very small population, and it's actually affecting the highest number of population being affected is in the US. And I would easily say that there are so many other countries that is also suffering from this disease, but due to the technological advances in US, they managed to discover this amount of people with these diseases faster compared to any third world countries, which are failing to actually pick out their the people who are actually affected with neurodegenerative diseases. So that's the reason we are looking into US having the highest population of people with neurodegenerative diseases. So, so the Icahn School of Medicine at Mount Sinai actually has conducted a rough studies in 2017 to actually look into the costing which is involved to treat or to handle these neurodegenerative diseases. So they have come up with, this Alzheimer's disease cost about 259 billion for the United States itself to cure. And medications for Parkinson care cost about 2,500 ringgit, $2,500 per year. And therapeutic surgery can cost up to 100,000 per person. But however, when it comes to therapeutic surgery, it's very subjective because when it comes to surgery relating to brain disorders, I would say it's about 50-50 chances. And the surgery that has been actually implemented for neurodegenerative diseases are also very minimal and it's very expensive. And the chances of you to get cured is not 100%, and definitely you can't get cured. The most that you can get is to just suppress the symptoms. So if you look at the medication for Parkinson care, it's about 2,500. This actually includes treatments like occupational speech therapies and other movement-related treatments like exercises, and that's the most we can do for Parkinson's as well. So moving on to the next slide. I'm going to talk about Alzheimer's and Parkinson's. I told you previously, so we are going to focus on Alzheimer's right now. So, okay, what is Alzheimer's? Whenever we talk about Alzheimer's, we also talk about dementia. Some people get confused what is dementia and Alzheimer's. So basically, dementia is the condition that we actually talk about in relation to Alzheimer's, or some people do address dementia as the initial stages of Alzheimer's. So basically, dementia is the general term for the symptoms like decline in memory, reasoning, or other thinking skills. So whenever a person starts having symptoms like losing memory, they can't remember where they put a glass of water and they start searching for the thing back. So these are falling under the category of dementia. So these things actually worsens making it into a disease kind of a situation. When it goes to a serious situation, like they couldn't even remember anything, then that's where it comes to Alzheimer's, which is a specific brain disease that accounts for 60 to 80% of dementia cases. So why do I put it 60 to 70? Because some of the dementia cases that people are suffering right now is just memory loss, which means this is something habitual or something that their brain couldn't cater, which is also classified under dementia, but it's not actually Alzheimer's. So when it comes to dementia or Alzheimer's, okay, let's say if you're diagnosed with Alzheimer's at the age of 60, I would easily say that at that particular age, your Alzheimer's would have been in stage 2 or stage 3, which is a quite severe stage compared to your first stage. And this first stage or the initial stages of Alzheimer's disease wouldn't be detected until the symptoms arise, which means if you're having Alzheimer's at the age of 60, your neurons are starting to lose their ability to function well or dying at the age of 40s or 30s. So it roughly takes 10 to 20 years in order for it to show its symptoms that you actually have this Alzheimer's disease. So basically 1 out of 10 people over the age of 65 at 80, and as per 2020, 5.8 billion people in US live with AD, and AD is the 6th leading death in the US, and 2 out of 3 of AD patients are women. So this disease is actually more prone to women when it comes to Alzheimer's. So Alzheimer's disease is an irreversible and progressive brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out the simplest task. So basically it attacks the hippocampus area, which actually plays role in, this memory and thinking skills and all these problem solving skills. So the early onset of Alzheimer's occurs between the age of 30s and 40s, which we couldn't detect, as what I mentioned previously, and we could only see the symptoms at the age of 60s. So looking into the background or history slightly on Alzheimer's, it has been named after Dr. Alois Alzheimer. In 1906, Dr. Alzheimer noticed changes in the brain tissue of a woman who had died of an unusual mental illnesses. And good thing is that because those days when people have some mental disorders or anything, they will say this person is mentally ill. But good thing is this person has actually examined the tissues and her brain after that, and she found out that her symptoms was actually memory loss, language problems, and unpredictable behaviors. After she died, he examined her brain and found many abnormal clumps. And these clumps currently is known as amyloid plaques and tangled bundles of fibers, and now called as neurofibrillary or tangles. So these are the major causes of Alzheimer's disease. So these plaques and tangles in the brain are the main features of AD. Basically, these plaques and tangles actually sits and clumps on the neurons and making the microglia to not clear up these plaques and tangles. That's where this neurons actually dies or it can't perform its function well. So another feature is the loss of connection between the nerve cells in the brain. I think everybody understands that a neuron is connected to another neuron, and the pass of information happens between neurons. And when there's a loss of connection between nerve cells or these neurons, there's no messengers going through. So, and that is also one of the reasons why that brain couldn't keep the memories or keep do the problem solving skills and everything. So neurons transmit messages between different parts of the brain and from the brain to muscles and organs in the body. Many other complex brain changes are thought to play a role in Alzheimer's too. To be very honest, brain studies are something that has never ended so far, because if you look at any organs in our body, we have actually finished studying and exploring those organs. But when it comes to brain, there's still so many unattempted part in the brain. And also the studies are still ongoing, and nobody has ever claimed that the studies on the brain has ended. So there are so many reasons that actually leads to Alzheimer's, which is still unknown, and scientists are still working on it. So this damage initially appears to take place in the hippocampus, the part of the brain essential in forming memories. As neuron dies, additional parts of the brain are affected. By the final stage, Alzheimer's damage is widespread and brain tissue has shrunk significantly. Okay, this one we are looking at the normal brain of a person and also Alzheimer's disease brain. If you look at here, the neurons are actually clear and it's actually performing their function well and nothing is on top of it. And this is the hippocampus. It is fully filled and there's no shrinkage over here. But looking at Alzheimer's disease brain, you see here that the neurons and all the tangles and the plaques are actually already on top or surrounded the neurons, and that causes the neurons to die and also to prevent all the messengers to be delivered to another neuron and also the work to be done as usual. And you can see here how badly the brain compartment, the hippocampus, is actually shrinking. And you can see a severely enlarged ventricles. There's a fluid between these ventricles. The larger it goes, the fluid is not not going to be higher as the space going high. So the connection between the cells also is reduced, and that's how people start losing their memory and everything. So this is a brain of a healthy patient. This is a mild Alzheimer's disease. This one I would say about 50s or 60s, and this one will be the third stage. This is severe Alzheimer's disease. And to be honest, most of them they identify Alzheimer's disease in the stage where there's an intermediate stage. Definitely early stages you wouldn't be able to identify, as mentioned earlier. But the moment when you identify the person is actually having Alzheimer's, is already like intermediate or to severe stage already. So Alzheimer's is one of the most terrible disease where you can't recognize yourself and also the people surrounding you. And not only that, severe Alzheimer's when it comes to normal or intermediate to severe Alzheimer's, you will lose your memory power, you will lose your movements, you will lose few other basic things that are actually being shared. But when it comes to the serious part, your body will even lose the ability to think how to breathe. Your body will even lose the ability to even do peristalsis after you eating. So this is the stage where we call it the last stage of Alzheimer's. But most of Alzheimer's patients don't even survive up to the last stage of Alzheimer's. So we rarely have cases like that to study. And this is the cerebral cortex, responsible for language and information processing. And you can look into the Alzheimer's patients. The cortex shrivels up, damaging areas involved in thinking, planning, and remembering. So it's basically becoming sharp. It's like, you have a freshly cooked rice, which is fresh and soft and it's following the shape. But the moment the rice is like, you let it out, dry it out, right? It becomes stiff and then sharp, right? So something like that. So this is the hippocampus area, critical to the formation of new memories. And here you can see the hippocampus shrink severely, causing the ventricles filled with cerebral fluid grow larger. So how can we know whether we are having Alzheimer's or people who are people around us is having Alzheimer's is with these symptoms? So basically the confusion with time and location, difficulty completing familiar tasks, misplacing items, difficulty solving problems, memory loss, poor judgments, unfounded emotions, trouble with images and spaces, difficulty with words, withdrawals from social activities. So these people, when they start losing their memories, they start losing, they start getting confused. Like what I said just now, they put a glass of water in the table and they don't even know where they put it. So this always happens with our grandparents or, people who are of elderly age. So, and when you see this situation happens, they will start withdrawing themselves from all the social activities from us as well. So in this situation, we have to be like very supportive enough for these family members to actually train their brain to get into the normal situation. But I know it's a bit hard, but some people have actually overcome this situation by suppressing the symptoms. So it's all, when it comes to brain, it's all about how we are handling it. So that's about Parkinson's disease. So moving on to, that's about Alzheimer's disease. So moving on to Parkinson's disease. So when it comes to Parkinson's, Parkinson's is all about movement and nerves, shaking, stiffness, and difficulty with walking, balance, and coordination. So it is also a brain disorder where it is related to the neurotransmitters or the dopamine level. So basically, Parkinson's symptoms usually begin gradually and get worse over time as it progresses, and people may have difficulty walking and talking. So they may have also mental and behavioral changes, sleep problems, depressions, memory difficulties, and fatigue. Both men and women can have PD, and somehow when it comes to Parkinson's, PD affects more men compared to women. Like Alzheimer's just now, we can see that Alzheimer's affects more women compared to men. So, and not only that, PD is a disease where we also detect it at the later stage, because initially we might think that it's happening because of anxiety, because every human being, when you go through anxiety or depression states, we start to shiver, we start to shake and everything. So some people tend to like avoid this thing and they think this is a very normal condition. So but this kind of normal condition actually worsens, and that's where people are dying, because of this Parkinson's. Because Parkinson's patient can fall anytime, anything can happen, and when they fall anytime because of the movement issues, it can also lead to strokes. So it also occurs when nerve cells or neurons in an area of the brain that controls movement becomes impaired or die. These neurons produce dopamine. So dopamine is the main factor for Parkinson. Even though there are other factors, we always look into dopamine first, because the lack of dopamine or the depletion of dopamine is the one leading to this movement issues. Because when the dopamine is not there, I'll explain to you all in the later slides. So when the neurons die and become impaired, less dopamine produced causes the movement problem. Scientists still do not know what causes cells that produce dopamine to die. So as what I told, brain studies still haven't reached its max. So we need more researchers as you youngsters in the room to work on the brain part. So people with Parkinson's also lose the nerve endings that produce norepinephrine, the main chemical messenger of the sympathetic nervous system, which controls the main function of the body, such as heart rate and blood pressure. The loss of norepinephrine might help explain some of the non-movement features of Parkinson's, such as fatigue, irregular blood pressure, decreased movements of food, to digestive tract, and sudden drop in blood pressure when a person stands up from a sitting or lying down positions. So this is another factor where it is non-motor symptoms. So many brain cells of people with Parkinson's contain Lewy bodies, unusual clumps of the proteins called alpha-synuclein. So basically, Parkinson is highly related to this Lewy bodies presence as well, and the clumps of proteins around the neurons. But when it comes to Alzheimer's, just now we talk about the tangles and also the plaques, which is actually being surrounded with the neurons actually. So although some cases of Parkinson's appear to be hereditary and a few can be traced to specific genetic mutation, in most cases the disease occurs randomly and does not seem to run in the family. So when it comes to genetically inherited, so we can't do anything much about it because, because of the genes, you might also inherit the Parkinson's disease. But most of the people who are suffering from all these neurodegenerative diseases, except multiple sclerosis, we would say they are not from the genetic, they are not affected because of the genes itself. So, but things like multiple sclerosis, spine problems, that also affects the brain and all. So it might also be one of the reasons to be genetics, but in these both cases, it's not really genetic based. But it can be genetic mutations that happens in your personal body due to chemical or toxin exposures or excessive stress and etc. So PD results from a combination of genetic factors and environmental factors such as exposure to toxins. Okay, these are motor and non-motor symptoms. If you can see here, these are the motor symptoms, which is bradykinesia. Vocal symptoms like when you talk to someone, these PD patients, they wouldn't be able to pronounce a word in full. They might be blurred speeches, or the voice might be tammering. So these are vocal symptoms. And rigidity and postural instability. You can see the ankle here. The ankle is a bit tilted, right? So you can see people who are, with Parkinson's, they are a bit shaky, unstable. They will have tremors. Tremors means shivering of hands. You can see their hands are always trembling, and walking or gait difficulties, and also dystonia. Dystonia is repeated movements. You can see some people having a blinking eyes, like keep on blinking non-stop, and some people, like this uncle, let's say, there's a possibility of this uncle to walk, put in the first foot right step and again step using the right foot, and definitely it's going to fall off. So situations like that falls under dystonia. So, and non-motor symptoms are likely to be mental or behavioral issues, sense of smell, they will lose the sense of smell, sweating and melanoma, gastrointestinal issues. And these gastrointestinal issues including urinary issues, weight loss, sexual contents, and also pain, joint pains. So it also includes depression, anxiety, fatigue, sleep problems, and also cognitive ability and personality changes. So these are the symptoms, and also, you know, how you can actually detect PD patients. So sometimes we do have people around us in our family itself who are suffering from all these things, but we are not really concerned because we see things like this as normal. So things develops until it gets worse. So this, okay, this is the dopamine level in a healthy patient. You can see this purple color is the one representing the dopamine level, and this is the Parkinson patient's level of dopamine. So the higher the level of dopamine, the better and the faster the neurons are transmitting the information. And if you can see here, the dopamine is there, so there's no medium to actually transport the information. That's why the movements are all affected. So when the messenger, okay, let's say you want to move to one place to another place, these messages are not transferred from your eyes. You are thinking and you're looking at something. This information is not being passed. If someone is going to pour hot boiled water, a normal person is going to escape. They're going to take a good run as far as possible, right? But this person's information are processed late, and sometimes the movement, the brain doesn't even trigger your legs to actually run away from getting, poured with the hot boiled waters. So that's roughly about Parkinson's and how and the causes of it. So we are moving into treatments. When it comes to neurodegenerative diseases, the treatments are very limited, and I'm going to talk some more on the Parkinson's disease. So in terms of medication, at least Parkinson's have some treatments which could suppress the symptoms, because Parkinson's it's very obvious because people can't walk and move around, right? So there's 4 or 5 types of medication group. So firstly, dopamine. So one of the way to treat is to give external dopamine, which means like levodopa, but levodopa is given with carbidopa together. And we also can give other forms of dopamine in oral dosage form or even in parenteral form. And this is going to replace that. This is going to help that lack of dopamine in the brain and to act and to help pass the information. So that is one group. Second thing is MAO-B inhibitors, monoamine oxidase inhibitors, and this slows down an enzyme that breaks down dopamine in the brain. So basically, MAO-B inhibitors, there's only 2 types of drugs there, which is selageline and also rasagiline. So these 2 drugs, their purpose is, okay, let's say you have a certain amount of dopamine in your brain. When you take these 2 drugs, it actually prolongs the depletion of dopamine, which means it helps you to keep the dopamine over there. Some people even take the external dopamine tablets, including MAO-B inhibitors. This is to make sure the depletion of dopamine is slower and the dopamine level in the brain is there, so that they can actually move around and it doesn't affect the transportation of the messages between the neurons. So others are COM inhibitors to help break down dopamine, amantadine, and all antiviral drugs to reduce involuntary movements, anticholinergic drugs to reduce tremors and muscle rigidities. Actually, there are quite a number of medications that is well known, and it helps to suppress Parkinson's in terms of movement disorders only compared to Alzheimer's. So the others like COMT, amantadine, anticholinergic drugs, these are most likely drugs which suppresses the symptoms. So, but in terms of dopamine and MAO-B inhibitors, it's a bit a long-term thing, and it also helps to work with the brain to make things natural. So when it comes to DBS is a deep brain stimulation, it's a surgery. So this is another treatment which you can look into when it comes to Parkinson's. And DBS is a surgical procedure that surgically implants electrodes into the part of the brain So they'll be like implanting the electrodes inside your brain, and they will connect it to a small electrical device which will be implanted in your chest. So this electrodes is going to help you in the transfer of information and in your movements, and also to work on your muscles. So this device and electrodes painlessly stimulate the brain in a way that helps stop many of the movement-related symptoms of Parkinson's, such as tremor, slowness of movements, and rigidity. And besides this, there are many other therapies like physical, occupational, and speech therapies. And you can also go for healthy diets that could actually improve your neurons' health, or your, your body condition, or something that actually helps your muscles to work better, and also exercises. We can also go for yoga, and there are some other Chinese-based treatments as well, which are quite well known for this Parkinson diseases that people are adopting right now. But I would say no matter how much medication or surgery you're doing, there's a high possibilities for the Parkinson disease to come back severe. So it's a bit hard to cure. So the bad news is there's no cure for neurodegenerative diseases, and you can only save yourself from the start. And okay, currently we are looking into what are the issues in treating brain disorder, because we have many drugs outside there for heart diseases. Even for cancer, we have actually looked into many medications, and there are always upcoming medications to treat all these disorders. But if you look into neurodegenerative diseases, the World Neurodegenerative Diseases Association as well has reported for the past 10 years, they have no reported new drugs that has been reported, or there's no new established formulation or medication that is coming up to treat these disorders. So basically, we are going to look at why is that so. So everybody knows that brain has the specific and also tedious material called BBB, blood-brain barrier. So this blood-brain barrier actually prevents the drug molecules to cross the blood-brain barrier. So why is that so? Because one, whatever that has to pass through this BBB has to be in a very small size. And I would say it's about 300 nanometer to 400 nanometer maximum to go inside this, to pass over this BBB layer. And not only that, most of the drugs that we are having right now are all hydrophilic in nature. When a drug is hydrophilic, when a drug is hydrophilic in nature, it hinders the drug from crossing the BBB. So we need to formulate this kind of hydrophilic drugs which can't cross that lipophilic layer of this BBB into a nanomaterial form which can pass by or which can cross the BBB layer. And that's where it comes the nanomaterials. I think there's another professor who has already discussed on nanomaterials in the previous days. And I'm also working on nanomedicine, which is coating all this hydrophilic nature kind of a drugs into a PLGA form or liposomes. We have many nanoparticles, nanosuspension, liposomes, micelles. So all these kind of and drug delivery systems are used to actually deliver drugs, Parkinson drugs or Alzheimer's drugs to pass into the brain. And not only that, most of the drugs that we're having for all these neurodegenerative diseases are in the oral dosage form. When you talk about oral dosage, definitely it's a poor it has a very poor bioavailability, it has to go through the first pass effect. And only 2% of the drug will be reaching the brain. So one thing is most of the neurodegenerative drugs are having very high side effects. That is one of the reasons we have to give it through the oral dosage. And over the oral dosage, it is more safer for the patient and reduce all this kind of toxicity level, which might directly impact the brain, because there are very minimal studies on these toxicity levels on these drugs as well. And we are actually looking into, like myself, I'm working on nasal delivery. So when you talk about nasal delivery and you talk about nanoparticles, it's a very efficient method where you can deliver a nanoparticle to cross the blood-brain barrier, and also to make sure the bioavailability is higher, you can just deliver it to the nasal cavity. So when things are delivered through the nasal, it goes faster and also the bioavailability is higher, and you can actually achieve that therapeutic efficacy faster as well. And not only that, when you formulate drugs into these nanoparticles, the dosage amount will also be reduced, and the reduced dosage amount is going to also reduce the side effects. So that's what we are looking into, the recent advances of neurological disorders treatments. Okay, so new approaches, this is what I've explained on the nanoparticles and nanotechnology. I think I've covered, and we are also looking into vaccines. I do understand that many people might have been a bit feeling weird on this vaccine part. I do feel weird because it's a very recent publication, I think, on Alzheimer's, and they actually didn't even expose in full. It was just an introductory that they are creating an Alzheimer's vaccine, and they are actually looking into some recovery, and also this vaccine is actually preventing the gene mutations from happening. So basically, I'm looking at in a way that this actually helps in people who are having Alzheimer's due to gene mutations, which means they are taking the sequence of the gene mutations and working on it. There are also some dietary supplements that also based on gene mutations. They look at the gene that is actually gene mutations, and they make it into a supplement, and they're also giving it to patients with PD and also AD. So these are a few new approaches that we are looking into, and you can look into the overview of current and future status of neurodegenerative diseases. So we are looking into 3 groups, which is 65 to 74, 75 to 84, and ages 85 and plus. So most of the time when the person is diagnosed with neurodegenerative diseases at the age of 65 to 74 or 75 to 84, the chances of them to survive up to 85 is very minimal. So here the motive is to just to illustrate how much, and over the years how much are we expecting. So you can see here in 2010 we have 4.7 million people who's diagnosed with neurodegenerative diseases, and in 2020, which is last year, about 5.8 million. 2030 we're expecting an increase, like a twofold increase roughly, 8.4 million. 11.6 in 2040, and 13.8 in 2050. It's going to be about 60% increase in this 30 years time. So, and one of the reasons is because of stress as well. So when we talk about anything to do with brain, stress level, working environment, pollution, all comes into a factor. And people which are being diagnosed or which are being studied with neurodegenerative diseases at this point of time are people who have lived in the 60s and 50s back then. If people's in 50s and 60s back then, with minimal pollution, with minimal stress level, with minimal stress of working environment and other factors where we don't have much devices to work on, and this devices actually causes radiation and death of neurons, and we already have this much of 5.8 million people affected. So we can easily assume how the trend is going to go on in future, right? So that's some of it. And this is the statistics from the US government itself on the population that is being affected, 13.4 million as well. And you can look at the cost of 1,167 billion has to be prepared by the end of 2050 to just in terms of Medicare, Medicaid, and also treatments, and also facilities to treat these patients. So that's about the statistics and the rough figure that we are looking into. Then, okay, we're going to move into the prevention of neuro disorders. So how do we help ourselves? I would say help ourselves, and also help our family members to keep ourselves in good terms, or in a good situation, so that we don't have to encounter any sort of diseases. As I mentioned earlier, stress level is the biggest cause or the contributor for most of the diseases that are happening to us. Heart diseases, brain-related diseases, tension, migraine, headache, everything is because of the depression that we're going through. And also when it comes to diet, also be very conscious about whatever you're eating, because when you are eating something that is not healthy, okay, let me give you an example. Okay, let's say if you're diagnosed with diabetes, right? We have actually recently discovered that diabetes, whoever who has diabetes is actually prone to having neurodegenerative diseases. So diabetes is causing Alzheimer's and Parkinson's as well. And this is because there's a hormone called GDNP, which is being affected or being reduced with the presence of, with the presence of diabetes. So you see, everything comes related to one another. So that's why we have to also maintain our diet and keep ourselves healthy so that we don't actually get ourselves into this Alzheimer's and Parkinson's. And not only that, once you are diagnosed with Parkinson is a best friend of Alzheimer's. So the moment you get Parkinson, you will also get Alzheimer's. The moment you get Alzheimer's, you will also get Parkinson. And the group, the family, the whole family will start attacking you. The whole neurodegenerative family will start attacking you. And then slowly you will start developing heart disease, kidney problems, everything. Okay? So because neurons are the most important part of our brain. And to prevent neuro disorders, reach and keep a healthy weight, regular exercise. One thing I would like to highlight on regular exercise is when you're exercising, you're breathing extra. And when you're exercising, definitely you're going to do it outdoor. Preferably do it outdoor, especially in this COVID situation and all, right? I do understand that many people have limitation to do things outdoor, but just try to have at least half an hour a day to do exercise outdoor, because outdoor activities actually increase the oxygen level that is being supplied to your brain. And neurons are very much dependable on oxygen. And also do have your body antioxidant level being scanned, and this antioxidant is also related to oxygen level that is being supplied to your brain. And also consume food that actually gives you all a high, rich in oxygen level as well. Drink a high amount of waters, and all this actually gives high level of oxygen to the body. And most importantly, have sufficient sleep. Sleep is very important because okay, when you're talking about brain, right? And also people who are not sleeping, let's say if you're practicing to not sleep or having minimal sleep in that day, in that one particular day, I would strongly believe that the whole day you might actually be feeling like something, you might have forgotten many things. You will feel like your brain is like literally a dreamland, when you're actually having lack of sleep, or you're not having a good sleep on that particular day. So this normally happens. And one of the reasons is your brain actually processes the whole information that happens throughout the day. For the past 24 hours, whatever that happens for the past 24 hours, all the information is being processed during your sleep period. And especially the period where 2 o'clock to 4 o'clock has been actually justified that or proven to be safe. Your brain actually works on data collection and organizing it into your memory section of the brain. So when you sleep less, or when you sleep at a very minimal hours, definitely you're losing the period where your brain is actually working to collect all the memories to save it inside your brain. So that's the major part of sleep. And healthy diet, and then you can take your dietary supplements, avoid stressful lifestyle, high radiation. Okay, now I have actually recently read the news that there's another 6G coming in less than 2 or 3 years. So imagine having a 6G phones, a 6G, internet fibers around your house, and you're sleeping with your handphones beside you, and you can easily say bye-bye to your neurons. So these are also one of the main important factors of neurodegenerative diseases. And pollution. Okay, when you talk about pollution and also toxic chemicals, right? Pollution and also toxic chemicals. Why is pollution and toxic chemicals plays a very high role in actually causing all the neuron deaths? As what I told you all, nasal delivery of drugs works most effectively. Why is that so? Because whatever that we are smelling goes directly to our central nervous system, directly goes to your neurons. That is one of the reasons why pollution and toxic chemicals is actually affecting or the major contributor to neurodegenerative diseases. So, and also avoid alcohols. And these alcohols actually also attacks your central nervous system. Anything that actually attacks your central nervous system is also a contributor for your neurons to die. So avoid alcohols as well. And maintain good health conditions. So as I told you all earlier, diabetes, tumor, stroke. I do know that tumor and strokes you can't avoid. If it happens, it happens. But just try to practice healthy lifestyle that doesn't lead to tumor and strokes. Actually, tumor is very subjective. It can happen to anybody, either by accidents, in long-term accident. I mean, if someone has accident in a very long-term and then you didn't actually encounter what what kind of damages or accident that happened to each part of your body, then it can actually have blood coagulation and causing all this tumor stuff. But when it comes to stroke is highly dependent on stress level, depression, working environment, your toxins, chemicals, pollution, or genetic. But when it comes to stress level and depression, I think stroke depression and stress plays the highest level in stroke actually. And avoid unhealthy working environments. So viruses also attacks your brain. So like now you can look into COVID. For COVID, we have no proofs or data that has been studied that how much this virus is actually affecting the brain. But there are studies that actually proven that this COVID is actually degenerating the neurons in the brain. So that is for sure. I just recently, 2 months back, I saw a publication that states that this COVID is actually making the neurons to die. In 20 to 30 years time, we might be prone to many other diseases or even neurodegenerative diseases. So be very careful on these viruses. And I think that's all from me. Any questions?
Thank you, ma'am. Thank you for your informative session. Before we move on to the query session, may I now request our beloved principal, sir, to hand over the e-certificate to our eminent speaker as a token of honor and respect.
Sure.
Just. Ma'am, kindly accept the e-certificate from Faculty of Pharmacy, Dr. MGR Education Research Institute.
Okay, thank you so much. Thank you.
Now I invite Dr. Vivekanandan, sir, to carry on the session. Over to you, sir.
Thank you, ma'am. Thank you. Thank you for your informative session regarding the neurodegenerative disease, ma'am. There are few queries that arise from the participant sides. And the first question from Dr. Hemlata, ma'am. What are the techniques where we can collect information about brain functioning, especially for Alzheimer's?
What are the techniques?
Yes.
Techniques or information about brain function. Okay. So basically, when it comes to neurodegenerative diseases, right, we don't have a specific diagnosis. That's why sometimes when it comes to Parkinson's, especially, right, people think that it's a normal shivering or normal tremor, and then we even the doctors wrongly diagnose because we don't have a proper diagnose system. But we do have some tests in terms of blood test and also some scannings that could be done to the brain to actually see whether it's you can see whether the brain is actually shrinking or not. So these are the basic things. Other than that, we actually, if you go to the normal hospitals or normal people, I think you can't do much about it. You only can detect based on the symptoms. And people are going to judge, based on what are the information you are giving to the doctors as well on the symptoms. That's it.
Okay, another question from her. What are the biomarkers used for Alzheimer's disease for in vivo studies?
Okay, for in vivo studies, right? There are quite a number, but I can't remember much at the moment. Maybe I will share some of the links to you later on. Is that possible, Ms. Vimalata?
Okay. The same, another question from her. For in vitro diagnosis of Alzheimer's disease, whether histopathological examination has been done only on post-mortem models.
Okay, so this case, right? Okay, histopathological models. Okay, normally it's a bit hard for us to get samples from real clinical samples, where people who are healthy, who's willingly going to donate their brain. That is for sure. It's very limited. Second thing is most of the studies has been done on the post-mortem models, which means the person has already died, and that's where we actually do the studies on it. So other than that, that's one of the reasons why I'm saying that the studies on this neurodegenerative is very limited and also stringent. It's a bit hard to study and also to do the histopathological studies as well. So, or either you can also take some part of the brain after they die, of course, and then you can do some, all these histopathological studies also. But most likely you can just go through over the scanning part and look at what is gone and what are the exact disease they were actually affected with, and how badly the neurons were dead. Hope that answers your question.
Thank you, ma'am. One more question from Mr. Praveen. Sexual activities and over sexual activities cause neuro disorders.
I would not say that, because actually sexual activities are being affected because of neuro disorders, not because of high sexual activities. It is causing neurodegeneration, because sexual activities are affected with the hormone. Because sexual activities is actually related to hormones, you see. The higher, when you're having sexual activities, it means having high level of dopamine release in your brain. So when the high level of dopamine release is happening, actually good for yourself. So that's why people say sometimes sexual activities actually makes us to remember things better, because the high level of dopamine is being released. And but I would not agree if someone says that sexual activities is the reason for neurodegenerative diseases. But sexual activities will be definitely badly affected if you are actually having neurodegenerative diseases. Definitely you can't do much, or you can't perform well in this case.
Thank you, answer all these queries. And going to top thanks on behalf of Faculty of Pharmacy, my privilege to deliver the I thank Mrs. Subhashini Raman for delivering a informative talk on neurodegenerative disease like Alzheimer's, Parkinsonism, MND, etc. on the much needed topic currently, because neurodegenerative disease is a public health nations worldwide, and it affects millions of people worldwide also. And also I thank for giving me an opportunity to deliver of time. Thank you, ma'am.
Thank you so much to all who have given me the opportunity, and I hope I have delivered something that is useful to everybody. If anything, you can just email me and I'll try to help you guys out.
Thank you.
I'll put the email address in the chat.
Thank you, ma'am.
Thank you.
And, next we move on to the next session by the speaker, Mr. Venkat Ramana, on the topic hepatitis C virus and hepatocellular carcinoma. Okay. And about the speaker, Mr. Venkat Ramana has completed his B Pharmacy at JNTU Anantapur in the year 2015. After CG, he has joined Masters in Medical Biotechnologies in the University of Del Piemont, Ferrante in Italy, and completed in the year 2018. And he was working with the COVID-19 biobank since April 1st, 2020 to May 31st, 2020. He completed his fellowship in a laboratory of clinical medicine, that's the Department of Translational Medicine in Italy in the year 2020. And he also worked in internal medicine laboratory, and he mainly focused on evaluation of echocardiographic alterations and polymorphisms of beta-adrenergic receptors in the patients with a chronic C infection pre and post therapy with DAE from November 2020 to April 2021. And the job-related skills are polymerase chain reactions and the DNA extraction, like ELISA test, cell culture, and he has participated in many conferences and presented their research papers, and he has published 5 research papers in high-impact journals. At present, he is a research fellow of Zandia University in Italy, working in the topic immune-based associated with the presentation and evaluation of SARS-CoV-2 disease, comparison between immunocompetent and immunocompromised patients, and it is a bias study. Okay, thank you. And participants are requested to mute their mic and post your queries in the chat box, and we will answer at the last. And now I welcome Mr. Venkatramana to take over the session. Mr. Ramna, sir. Mr. Venkatramana, sir. Sir, you can share the slides. The voice is not audible, sir. Sir, your voice is not clear. Voice is not audible.
No, sir, we are not able to hear you, sir.
Yes, yes.
No, sir, we are not able to hear you, sir.
Venkatramana, sir, join with audio, sir.
We are able to see your video, but we are not able to hear you, sir.
Kindly try without your headphones, sir.
No, sir. Not able to hear you, sir.
Sir, audio is not connected, sir.
Komalman.
No, sir, we are not able to hear you, sir.
அண்ணா சந்தியா வர சொல்லுங்கண்ணா.
Participants, please wait. He's having issue with his network. Please wait just for 2 minutes.
Hello.
It's getting echo. I'm not just you log out from my laptop.
Okay.
So you can share.
Hello.
Yes, you can share your PPTs.
Sir, just 1 minute, sir. You are hard to my voice?
Yes.
Okay. Just a minute.
Is the screen visible, Rama sir?
Yes, sir. Sorry for the trouble. I have some connection here. Can you hear my voice?
Yes, you can start, sir.
Okay. First, I would like to thank you each and everyone who are participating in this international conference. I am very glad to participate in this program. First, I would like to thank giving this opportunity to Faculty of Pharmacy, Dr. MGR Educational and Research Institute. And I would also thank Principal Sir, Dr. N. Harikrishnan, Faculty of Pharmacy, Dr. MGR Educational and Research Institute. And my special thanks to Dr. Vivekanandan, Associate Professor, who are working in Faculty of Pharmacy, Dr. MGR Educational and Research Institute. And coming to the topic today, I am going to discuss hepatitis C virus and hepatocellular carcinoma. Here, coming to the next slide, here you can see, you can imagine what I am going to represent today. The whole process, how the hepatocellular carcinoma, it can lead to the disease progression. There are several factors including in this progression of diseases, not only one. So I can give you a brief idea about what are the factors include the disease progression. So mainly we can consider alcoholic related diseases and hepatitis virus related diseases like hepatitis C virus and hepatitis B virus, and there are some toxins. And there it's now present trend is metabolic disorders like non-alcoholic fatty liver diseases and non-alcoholic steatohepatitis. This when it affect the healthy liver, it can lead to the chronic inflammation, or when it become chronic inflammation from acute to chronic inflammation. In acute phase, it can be cured 3 to 6 months. When it become chronic inflammation, maybe it can lead to the directly hepatocellular carcinoma, or it can be go through fibrosis, and later it can lead to the cirrhosis, and then finally it can lead to the hepatocellular carcinoma. Here what are the topics today I'm going to discuss. I can give you the brief idea. So here coming to the introduction and background of hepatitis C virus, and there are some classification of hepatitis C virus, and the main symptoms, what are the symptoms is hepatitis virus, and there are some metabolic disorders, and there are some genetic studies, and some diagnosis, and the mainly medication, and they finally conclusion. Coming to the slide introduction, globally liver cancer is the most common cause of diagnosed liver cancer type, and with fourth leading cause of death. And 70 to 80% of the cancer, hepatocellular carcinoma, is the most frequent liver cancer, and chronic infection with hepatitis C virus. It has been recognized as a major cause of hepatocellular carcinoma. There are the main therapy for this one. It's like we will call it direct acting antiviral agent, DAA. The standard therapy for achieving high rate of sustained virological response, SVR, which is associated with highly reduced for the mortality and hepatocellular carcinoma. Background of hepatitis C virus. Hepatitis C virus. Sorry, sir. Okay. Background of hepatitis C virus. Hepatitis C is the enveloped positive single stranded RNA virus, and it's a Flaviviridae family, which was discovered in 1987. Then hepatitis. Coming to the next point, hepatitis C infects predominantly infect the hepatocytes, and there are other factors like peripheral plates, mononuclear cells, and including dendritic cells and B cells and T cells. The natural history of chronic liver diseases is highly variable, ranging from minimal histological damage, fibrosis to cirrhosis, and later hepatocellular carcinoma. Here, some classification, I can give you the brief idea. The hepatitis, it can be classified to the divided into 5 groups: hepatitis A and hepatitis B and hepatitis C and hepatitis D and hepatitis C. And hepatitis A and B and C is a positive single stranded RNA, and B is a double stranded DNA, and D is a negative single stranded RNA. So it can be transmitted through either eternal or parental. Sir, next.
Please wait. There is issue in that sharing.
Okay.
Yes, now we can.
Okay. Here we can see how many cases are for a year. Hepatitis B and hepatitis C is 400 million cases per year in the world, and gradually death is 1.4 million people will die because of the chronic inflammation. And treatment is 90% of people hepatitis C patients can be healed with within 3 to 6 months, as I mentioned before. How the virus it can be spread. They mainly hepatitis A and E, lack of food hygiene and contaminated water and sustained sanitary facilities. And coming to the hepatitis B and C and D, it can be spread through blood and sperm and other body fluids, etc. There are main symptoms causes of hepatitis like fatigue, loss of hepatitis, and abdominal pain, and like diarrhea and joint pain and jaundice. These are the symptoms mainly affecting the who are affecting the hepatitis virus. So coming to the metabolic disorder, as I mentioned before, coming to the slide, metabolic disorder like non-alcoholic fatty liver diseases. Non-alcoholic fatty liver diseases, a chronic cause of chronic liver disease. It can be described a wide spectrum of fatty liver changes. It can be progress in a simple steatosis from one way, and other hand, it can go through NASH, non-alcoholic fibrosis. Then it can lead to the fibrosis, then later cirrhosis, and finally it can lead to the hepatocellular carcinoma. NAFLD has become progression like alcoholic liver disease, but not caused by chronic alcoholic consumption. NAFLD has become increased common in parallel with increased prevalence of obesity and type 2 diabetes mellitus and hypertension. And NAFLD progression is affected by the both environmental and genetic factors. Coming to this slide, NAFLD is one of the most common cause of liver diseases worldwide, and how the major cause of liver related deaths. And now NAFLD begins with a lipid accumulation, and marked hepatic fat accumulation is a risk factor for disease progression. NAFLD are well established more than 50 years, who are with obesity and type 2 diabetes, militant and insulin resistance, and there are some genetic factors like like phosphatase domain containing 3 polymorphism, and coming to there are main we are working with these main 2 genes. 2 main genes involved in the disease progression like PNPL3, and another gene is HSD17 beta 13. So these are the which are published related to NAFLD and HCV and hepatocellular carcinoma. Our group in 2019, which we published in severity of non-alcoholic fatty liver diseases in type 2 diabetes mellitus, relationship between non-genetic factors and PNPL3 and HSD polymorphism. And the other one is interplay between both genes variants in modulating the risk of hepatocellular carcinoma and among hepatitis C patients in 2020. So coming to the slide, I can give you the brief idea about what is PNPL3, what is HSD17 beta 13. One is PNPL3 is a patatin-like phosphatase domain containing 3, is a 481 amino acid mainly expressed in hepatocytes, and the single SNP means is a single nucleotide polymorphism. Variation is a C to G substitution, which leads to the isolation to methionine exchange at amino acid 148. They mainly it's expressed in hepatocytes and increased in triglyceride and free fatty acids, and very low density lipoprotein secretion. Very low density lipoprotein and NAFLD and NASH development. Coming to the HSD17 beta 13, this one also it can expressed in liver and 300 amino acid protein. The variant is adenine insertion adjacent to the donor splice exon 6. The mutation it leads to the truncated protein, which is associated with the reduced risk of chronic liver disease and disease progression from steatosis. Coming to the next slide, here we can see the normal function of the hepatocytes and hepatic stellar cells. When it's the triglycerides, it can lead to the fatty acids and glycerols. It can go through ApoB and normal function and a very low density lipoprotein. And hepatic stellate cell, it can release to the retinoester, convert to retinol, and it can go through cellular metabolism. The other when the PNPL3 isolation to methionine insertion, we can see this function will doesn't work. So because of this, the disease progression, we can see lot of progression in the disease and like NFLD and NASH and mainly hepatocellular carcinoma because of this methionine isolation to methionine exchange. There are several studies have documented an isolation in polymerization with the progression of the disease and the development of hepatocellular carcinoma and non-viral liver diseases in the chronic hepatitis C. The association with the progression of the disease has been widely documented with the association with the development of hepatocellular carcinoma remains controversial. See, coming to the mechanism of HSD, HSD 17 beta 13, the recent work has been identified a protective role of the variant that would appears to be able to curb the progression of the disease and the development of the hepatocellular carcinoma in the non-viral liver diseases, and that would be also be able to modulate the increased risk of association with the presence of the PNPL3 mutation. In this context of chronic hepatitis C, the recent study we confirmed that our group and there are many researchers confirmed that a protective role the HSD 17 variant against the progression of the lacking progression of hepatic fibrosis, and but convincing the data are still lacking regarding its role against hepatocellular carcinoma and in interaction with PNPL3 polymorphism. So here the genotyping which we are working PNPL3 and HSD 17 beta. Our group mainly I can explain briefly what is the wild type, what is the heterozygous, what is the mutation. So mainly which are the methods we are used for this one. We are collecting the samples from diabetes patients and NAFLD patients, and later we can do the blood processing, and then later I will extract the DNA, then I will do the genotyping all the patients. We will repeat the same procedure 2 times DNA samples genotyping. If the 2 times it's matching, we will not repeat the 3rd time. If the 2 times it's mismatch, we can repeat the 3rd time of the patient sample. We will confirm the which is the wild type, which is the heterozygous, which is the mutation. So coming to the PNPL3 polymorphism, here the C and C 154 patients is carrying wild type, and C and G 139 patients carrying a heterozygous mutation, like only one allele is mutated, and C and G the 35 patients carrying the mutation. So PNPL3 gene 46.8% of our patients cohort carrying CC wild type genotype, and 53.2 carrying SNP, at least one allele is damaged. And coming to the HSD 17 beta 13, there are same study we conducted this gene also. 223 patients carrying the wild type, and 90 people carrying the only one allele mutation, and 15 patients carrying the mutation A insertion, which I explained before. HSD 17 beta 3 gene 68% resulted wild type, while 32% of patients have the A insertion in the spliced donor site TTA instead of TT. Coming to the slide, HSD 17 beta 3 variant decreased fibrosis. Liver here we conducted a multivariate analysis liver fibrosis distribution among who carrying a PNPL3 genotyping based on the based on carrying of HSD variants. Here we can see it's increasing disease progression wild type to heterozygous to mutation. The statistically significant is p-value is 0.008, but we didn't observe any statistical significant the A insertion, so it's disappear comparing to the PNPL3 insertion wild type. So there are next slide, coming to the next slide. HSD 17 beta 13 variant is associated to liver damage in the female diabetic patients. Several serum alanine amino transfer ALT level is a female figure A and male figure B. Based on the PNPL3 HST genotyping, we can see here who carrying PNPL3 wild type and PNPL3 mutation. We can see the figure A, female diabetic patients. We can see the statistical significant higher ALT level, and it can lead to the fibrosis stage. And we didn't observe the same effect in male cohort. So there is no statistical significance in male cohort. We observe only in female cohorts. And coming to the slide, the liver stiffness we conducted based on the body mass index. The predictive value of liver stiffness based on the PNPL3 genotyping and was body mass index. Error was indicate 95% confidential intervals. The upper horizontal based on the dot lines indicates liver stiffness value suggestive of the cirrhosis. The lower one value suggests options are minimal fibrosis. Here there is another study we conducted in our laboratory in the 2020. Same effect. Here we took only who are infected with chronic hepatitis C virus. So as always, the two genes. We conducted 440 patients, different categories, F0 to F1, F2, F3, and F4. Yeah, and hepatocellular carcinoma. F0 means there is no fibrosis. F1 means is a mild fibrosis. F2 means moderate, and F3 means moderate, mild and moderate and severe. And F4 means it's a cirrhosis, and HCC means hepatocellular carcinoma. So based on this, we see the who carrying the wild type, and it's a the graph is we can see the graph. It's decreasing, and who carrying the G mutation, it's increasing the frequencies. So it's statistically significant. Is a p-value is a 0.007. So we confirm that this polymorphism it's strongly associated with disease progression. Coming to the slide, genotyping and allele frequency for PNPL3 and HST 17 beta 3, and as always here we conducted number 243 HST 17 beta wild type TT in the PNPL3 genotyping percentage. We can see all F0 to HCC, the who carrying the wild type, it's complete it's decreasing order. The alternatively it's who carrying the mutation is completely increasing in the who carrying the wild type HST 17 beta 13, and you can see figure B. Here we conducted only 197 patients who carrying only HST 17 beta 13 mutation, and as always CC wild type PNPL3 and G it's a mutation. So here the F0 to F1 it's blunted the changes, and F2, 3 and HCC the as usual the progression of disease is increasing, and wild type it's decrease the progression. So it's interpreted the disease progression. So we confirm that it's playing a very vital role in the chronic inflammation and hepatocellular carcinoma. Our cohort study. And there is another article which we published like a periostin circulating level and genetic variants in a patient with non-alcoholic fatty liver diseases in international journal like Diagnostics 2020. So I can give you the brief idea about what is the periostin. Periostin is also known as an osteoblast specific factor. 2 is a 90 kilodaltons multifunctional extracellular matrix protein mainly secreted osteoblasts Those periostin consisted of 811 amino acid residue belongs to the facet family member. It has a physical protective effect on the organism, including remodeling of extracellular matrix and wound repair in the muscles and vascular injury and the fraction and maintain the bone and teeth and heart development and the healing of tissue after the acute myocardial infection. Considering the human studies, the relation between periostin circulating levels in hepatic steatosis, which is in the basis of the present study. The coming to the slide, the upregulation of the hepatic periostin circulating levels expression in NAFLD patients, which is a good correlation with the hepatic triglyceride content. On those, the hepatic plasma periostin circulating concentrations were observed in NAFLD patients in compared to healthy control. We didn't observe any correlation in healthy control, but strongly correlation with NAFLD patients in periostin circulation level. And in addition, circulating periostin levels was strongly associated with the lipid metabolism and chronic inflammation and insulin resistance. So as I mentioned previously, these three, it's a main playing very important role in the disease progression, either NAFLD or HCO or HCC. The serum and liver tissue levels, the periostin circulation were closely related to the decline of liver function and the pathological stage in NAFLD patients. So coming to the slide, here we conducted a total 182 patients. 74 patients are NAFLD and 81 patients are HCO and 24 patients are healthy control. We can see the trend towards statistically significant different among groups. The p-value is 0.06. We can see the red dots is hepatocellular carcinoma, NAFLD, non-alcoholic fatty liver disease, and HCV hepatic C virus. So there are other genetic factors also, including the disease progression, not only the two genes which I explained before, but now we are working on these three genes. We are focusing on, we already done in this year a lot of study. Almost we conducted 1,000 patients in both NAFLD and HCU, but it's going on the study. So there are like we will call trans member 6, super family member 2, and the other gene is MBO8T7, and the other gene is a GCKR mutation. So these three genes also, it's the world genome-wide studies recognize its progression of a chronic inflammation and NAFLD and hepatocellular carcinoma. So I can give you the brief idea what is the function. Transmembrane superfamily 6 is involved in the enrichment of triglycerides to apolipoprotein in the pathway of very low density lipoprotein secretion from the hepatocytes. And this polymorphism, it encodes the E to A substitution at position 167, resulting in the loss of function inducing higher liver triglyceride content and lower circulating lipoprotein. And coming to the other gene, MBO8T7 is a common genetic variant associated with the downregulation of MBO8T7 at mRNA and protein levels, and you reduce level of phosphodiisonol containing arachidonic acid in hepatocytes and the circulation. And the common missions loss of function, a GCKR mutation encodes the for P446L protein variant, seems to prevent the cause variant underlying the association with hepatic fat accumulation. So coming to the diagnosis, obviously, if you need to diagnose, there are several factors include. So here I can see when it's teaching the patient the cirrhotic phase, definitely we have to consult the doctor. We have to see how the stages of our diseases. So here we can see the nodule size in the liver. If less than 1 centimeter, we can follow up the patients at least to 3 months ultrasound. Or if you more than 1 centimeter, it can go through typical feature of a CT or MRI scan, CT scan or MRI scan, and we can confirm that the patient is it's a hepatocellular carcinoma or not. Or it can go through a typical feature CT or MRI scan. We can go through biopsy. We can take a small piece of from liver, and we can do cell culture, and we can see how the patient is growing the disease. We can confirm the hepatocellular carcinoma. If it become the after biopsy it become negative, again we can continue the second biopsy. Then we can confirm that it's hepatocellular carcinoma. Or after the after following the 3 months, or we can confirm that ultrasound units maybe the patients come it's negative. We can go. So here I can show you some images. The diagnosis CT scan or MRI. So we can see in this figure which I marked arrow mark. These are the CT scan of hepatocellular carcinoma invading the pain portal, and the MRI scan which I marked the black arrow marks. So these are the MRI hepatocellular carcinoma. You can see there is a nodule. It can lead to the very high level of cancer. So obviously, when you confirm that the patient is cancer, the hepatocellular carcinoma, so obviously we need some treatment. Either we are using drugs or some other treatments. So here we conducted the present trend is more effective DAA based on therapy. There are 3 classes of currently recommended for DAA medication: NS3, 4, and A protease inhibitors, and NS5A polymerase inhibitor, or NS5B polymerase inhibitors. So I can give you the 3 explanation. As I mentioned, NS4A viral protease inhibitor used in the combination with other antiviral for the curative treatment for hepatitis C virus infection who are infected with hepatitis C. And then a non-structural protein 5A NS5A inhibitor is mainly, which I mentioned before, DAA, direct acting antiviral agents that target life cycle, that target viral protein, and their development was culmination of increased understanding of the viral life cycle combined with advance in the drug discovery technology. And NS5B polymerase is responsible for viral RNA replication, and the catalytic site of NS5B protease in a highly conversible across in a different Hakachu genotyping. So making nucleotides inhibitors that targets this protein appearing the treatment option. So based on we can use different drugs based on these inhibitors. So we can stop the replication and cell cycle, and we can stop the disease progression, and at least we can cure the not 100%. We can cure the 90% of patients who are taking the DA treatment. Our study, the high rate of severe response. We are eliminated for the virus from the body. So I don't want to, coming to this slide, I don't want to go in detail. Structure of hepatitis C RNA, which I marked 3, which I explained before slide, NS3 and NS4A, and NS5A and NS5B. These are the inhibitors. We target stop the progression and cell cycle and RNA replication, and we can we can give some drugs and we can stop the disease progression based on the inhibitors. So here there is obviously we need some drugs to medication who are affecting this cancer. So here there are some generic names from first line hepatitis C virus DAA medication. There are some drugs is there like lepipasvir and sopasvir is we will use it's very useful drug for the first line therapy for who are treating with the DAA medication. And there are some other drugs also is there, but in our study we will not mention as well, but we will use most of the drugs is observation LDU and SOF. And which I explained the previously about the inhibitors. So here we can use different drugs or different inhibitors stop the cell cycle or RNA replication or other disease progression. Like we can see the first which I explained here, we can use some cases we can use the ribavirin. Also we can use the stop the, but it's not all cases. It's based on the patient criteria, what are the effects he's facing. So based on that we can use this drug also. Lepipasvir and sopasvir and ribavirin, a combination of NS5B protease inhibitor and NS4B. We can use these both inhibitors to stop the disease progression. And coming to the next, and elbesvir and grassopivir and plus ribavirin, and we can use only NS5A and protease inhibitor and NS5A polymerase inhibitor. And there is no study we see in NS5B polymerase inhibitors. And the same as well, but we will not focus on in detail the other drugs. So here, coming to the slide, number of DAA tablets for a day. Who are taking a DAA treatment? How many tablets we have to take per a day? Who are treating with the hepatitis C regimen? So here we can say the first and sopasvir will take 2 doses per a day, and 2 tablets per day. And how many tablets are here? Here we can see the how many DAA tablets taken for a day. It's here 1, and ribavirin. It's as I mentioned previously. It depends upon the patient criteria. If we have some other health issues, we cannot suggest to take ribavirin. And as well as the ribavirin adds 4 to 6 capsules per day. If someone want to take, if they doesn't have any other complications to take this medication, so we can suggest that okay, you can take the ribavirin capsules. So coming to the conclusion, as I mentioned, all the study which I previously I represent, the genetic relations between a 2 variant PNPL3 and HSD17 beta 13 and NAFLD patient progression in the cohort of diabetic patients and C virus related to HCC progression. And then diabetic patients carrying PNPL3 mutation gene showed an increasing liver stiffness, which is correlated with the fibrosis state, which I explained before slides. And those who are carrying the HSD17 beta variant mutation had a protective effect of fibrosis progression. In fact, the patients carrying both PNPL3 and HSD mutation showed the similar fibrosis states in the patients with the PNPL3 wild type, which I mentioned, which I explained in the previous slides, 440 patients. So this effect we observed in our study. Though furthermore, HSD17 variant has a protective role against hepatocellular damage based on ALT level, especially in females. So finally, I conclude that all over the world, estimated cases 700 million people living with chronic hepatitis infection worldwide, and in liver diseases burden remaining approximately 400,000 deaths per year from the liver failure and liver cancer, and the minority possibility only 20% of people with chronic hepatitis C virus diagnosed, and estimated 1.5 million people newly infected with hepatitis C virus each year in the especially in ASEAN, uh, American, Eastern American, and European countries, and coming to the advanced development of we have to say they who are working in the really in the research field, the advanced technology of DAA therapy, direct acting antiviral therapy for chronic hepatitis C infection is one of the great advanced and clinical medication in the past few decades. And finally, we conclude that the main our motive of our aim is to eliminate hepatitis C virus, and the World Health Organization and 2030 the global elimination target for hepatitis C virus, and 80% of who are eligible to treat 90% of reduction in the incidence of the new infection, and 65% of reduction in the liver related mortality, and acknowledgement here. I would like to thank each and everyone who are participating in this webinar, and especially this is our we are working in our group. Professor Mario Pires, he is a hepatologist in director of internal medicine laboratory, and Professor Firpalo Sagna, he is a rheumatologist and he is working in an internal medicine laboratory, and my coordinator in my laboratory, and Dr. Rosalba Minizini, and I'm working in with them. I'm very glad to having this opportunity to, and thank you for your attention. If you need any questions, you can contact me at this email ID anytime. It's my pleasure, and thank you.
Thank you, sir. Thank you for your in-depth explanation on the topic. Before we move on to the query round, may I now request our principal, sir, to hand over the e-certificate to the speaker as a token of appreciation. Sir? Sir, kindly accept it from Faculty of Pharmacy. Kindly accept the e-certificate from Faculty of Pharmacy, sir.
Yes, ma'am. Thank you so much. Thank you so much giving this opportunity.
Thank you, sir.
Thank you.
May I now request Mr. Sai Rahul, sir, to take over the query round. Over to you, sir.
Yes, ma'am. Thank you. And thank you, sir, for your valuable information on hepatitis C and hepatic carcinoma. There are some queries as well.
Sir, we are not able to hear your voice.
Now, ma'am, can you able to? Can you
put your mic near?
It's very low.
Okay. How about now, ma'am?
Yeah, it's very low only. Put your mic near your mouth.
Okay, ma'am.
Yes.
Okay.
Yes, please.
Yes. So thank you so much, sir, for your valuable information on hepatitis C and hepatic carcinoma. There are some queries that have been asked by our participants and faculties. So the first question is asked by the Shalini ma'am. Who should be tested for the hepatitis C virus on routine basis?
Sorry, can you repeat the question?
Who should be tested for hepatitis C virus on routine basis?
Basically, we will take the alanine aminotransferase and asparase aminotransferase and GGT. These are the liver enzymes, especially in our liver. So based on this, we will confirm that these patients could be affected on the disease progression. So especially which I explained before, we observed in a female cohort study, it's a more severe progression in the fibrosis stage. So mainly these protein expression, we can consider that maybe it could be effect on some viral infection. So based on this liver enzymes, we can consider the patients could be affected on the virus.
Yes, sir. Thank you. And another question from Saint Charlena. Is this hepatitis C can cause any mental disorders or any regarding mental problems?
Until now, which I read, I never heard about the mental disorder, but we can say that there are many factors associated. It can lead to the multi-organ failure. I have read some studies which published, so it can may cause through several like diabetes and nephrology and NASH, which I explained. These are factors can influence the liver failure, but the mental status, I don't think so. It can be affect on the liver. But as I said, yes, obviously we need without a stressful condition. If it take a stressful condition, there are many factors affecting our body. So we can be stressless.
Yes, sir. Thank you. And another question from Haripriya. Is that there's a risk for hepatitis C infected women when they give breastfeeding, sir? During breastfeeding, are they advised to give when they have been affected with the hepatitis C virus?
I think when we confirm that the patient have the hepatitis C virus or something like that, it's not so good to give the breastfeeding, because it can be transmitted to the from person to person, from mother to child. So it's not so good. So Western countries, there is they won't give the breastfeeding because there are many diseases, especially in Eastern Europe countries. There are many people affecting in this virus, so they won't suggest to give the breastfeed.
Yes, sir.
I
Thank you
don't
so
think
much.
so.
Yes, thank you so much, sir, for answering all the queries. It would be clarified person to ask the queries. Thank you so much, sir.
And thank you so much giving this opportunity once again to all who are participating in this program. And thank you.
Yes, sir. Thank you so much. So now we are just moving on with the vote of thanks. And
Okay.
on behalf of our faculty of pharmacy, it's my privilege to deliver the vote of thanks. First and foremost, I would like to register my heartfelt gratitude to our management, founder, chancellor, Dr. A.C.S. Shanmugam, sir, Honorable President, Dr. S. Arun Kumar, sir, Honorable Secretary, through A. Ravikumar, sir, under whose relevance all our efforts are taking shape. The Vice Chancellor, Dr. S. Geetalakshmi, ma'am, for constant support and guidance. I'm extremely thankful to the speaker to grace this occasion with their valuable and informative talk. My sincere thanks to Ms. Subhashini Raman, Department of Pharmaceutical Engineering, Malaysia, for spending her valuable time and sharing the importance of neurodegenerative diseases. Followed by my sincere thanks to Mr. Venkata Ramana Malaya, Research Fellow, Dean Novara, Italy, who just given an excellent speech on hepatitis C virus as well as the hepatocellular carcinoma. And last but not least, my sincere thanks to our beloved principal, sir, for his guidance and encouragement in all our efforts with participants. I thank all the participants, students, and faculty members present for this webinar. Thank you all. And participants are requested to fill their feedback link that has been posted in the chat box, which will be active till 10 p.m. today. And also, there is a small announcement regarding tomorrow's program, day 4, which will be starting at 10 a.m. sharply with two most intellectual speakers with the same meeting link. Dr. Palani Swami Sivanandi, Faculty, Department of Pharmacy Practice, Kuala Lumpur, Malaysia, who is going to speak on the topic of importance of mental health during the COVID-19 pandemic and ways to achieve it naturally. And Dr. Mahendra Segar, Associate Professor, Faculty of Pharmacy, University of Kuala Lumpur, Malaysia, who is going to speak about the topic on drug delivery of natural products in time for neurodegenerative disorders. And followed up, there will be an regulatory program that there will be a talk by our Chief Guest, J. Jayasilan, Chairman, IPA Industry Division, Chairman, IDMA President, Tamil Nadu Pharmacy Council of India. So I request all the participants to be active throughout the session tomorrow to avail your e-certificates. See you all tomorrow and thank you for being participating.